Hello and welcome to our program entitled Beyond Borders in Relapse and Refractory Multiple Myeloma, Optimizing BCMA Bispecific and CD38-based Combination Therapy. My name is Dr. Joseph McHale. I'm a professor at the Translational Genomics Research Institute. You can see my disclosures here on the screen, and this is an educational activity that is supported by an educational grant from Johnson & Johnson. Lastly, the learning objectives for today's programs are displayed on the screen, and you can see here that we are going to be diving in deep to bispecific antibodies and their combinations and all of the other great options that we now have in relapse and refractory multiple myeloma. Well, now let's discuss implementing combination therapies of bispecific antibodies and how sequencing is going to influence our decision-making in relapsed multiple myeloma. So first of all, as we pragmatically think about how we treat patients with these therapies, these are a little different than many of the therapies that we've historically used. Key is there is the risk of cytokine release syndrome. Of course, we don't have to give you a long lecture on cytokine release syndrome. I'll share with you as we go through how we manage some of it and more specifically. But the principle of cytokine release syndrome, of course, is that when we give patients a bispecific antibody and these T cells are engaged, it's a shock to the immune system. They're not used to seeing this happen, or the immune system is not used to seeing this happen, and it can release a sort of a cytokine storm. And so we want to minimize that. And one of the key ways in which we minimize that is that we provide these drugs, almost all of them, as a step-up dosing strategy, meaning we give much lower doses of the drugs initially to, if you will, prime the immune system to be aware that it's coming so that there isn't as large a reaction if we had given the full dose of the drug. So you can see here from the slide that for the three BCMA-directed bispecific antibodies, teclistamab, elranatamab, and linvoseltamab, we have a step-up dosing process. They're each a little bit different. The linvo, for example, is given IV versus sub-Q for teclistamab and elranatamab. The days differ, and even though we see, for example, with teclistamab that originally was given day 1, 4, and 7, sometimes it can be given even 1, 3, and 5, depending on the different institutions that may be delivering them. But the principle is the same, that historically many of these patients were actually hospitalized. Again, we're going to talk in a few minutes about moving towards more of an outpatient management of it. But the principle being that we need to monitor patients a little bit more closely. We give lower doses of the drugs to build up to the standard dose so that we can reduce that risk of cytokine release syndrome, which typically initially presents just as fever. That's often the very first symptom and sign of a cytokine release syndrome, but this can be followed by hypotension, by confusion, by all sorts of other effects that you see here, and we want to intervene as quickly as possible. In the early days, we kind of let it happen and then reacted to it. Now there's a greater interest in intervening quickly, or as I'll share with you also in a couple of minutes, potentially even preventing it by giving prophylaxis even before patients have their treatment. So for example, with teclistamab, we've moved to a strategy where initially it was day 1, 4, and 7. Many centers are compressing that into day 1, 3, 5, so it can be done in the same calendar week of Monday, Tuesday, Wednesday, Thursday, and Friday, so that patients can get their full treatment within that. And we do give these very specific pre-medications, as you see here. And now, as I'll share with you in a moment, there's a greater interest of even using prophylactic tocilizumab to be able to do it. Part of it now, as we combine with other therapies, that was how we gave it monotherapy, is we combine it, like when we combine it with Tecdara, there's actually been a change in how frequently we give the drug, whereas teclistamab was historically given weekly. With Tecdara, the Tec dosing follows our classic Dara dosing of weekly for 8 weeks, every other week for 16 weeks, and then once every 28 days. So this is designed together to give the best outcome, but also to reduce the risk of toxicity. Well, on the subject of giving outpatient dosing and finding more convenient ways to do it, there was this BOSS program. I like it being called the BOSS program. I think that's a cool way to describe it. As we think about trying to find ways to move it from inpatient to outpatient, we all know how difficult it is to get a bed. We all know that patients would prefer to sleep in their own beds and sleep in the hospital. And it's really just a better use of resources in general if we can do this as an outpatient. And so as a more careful strategy was used where we can monitor patients sometimes remotely, engage their care partners, have ways of doing this, we demonstrated, the BOSS program demonstrated that it was very feasible to be able to do this, that we did not see excessive amounts of cytokine release syndrome or infections or other challenges throughout. So as every center works their own BOSS, their own program differently, I think we are going to see a much greater use of outpatient dosing. I can tell you for me and my particular center, we try to provide these exclusively as an outpatient so that we can make it easier for our patients. And it requires a partnership and it requires an engagement. And often that's very good, we found actually, because that communication line can be open. We can remotely monitor some of these signs and symptoms like their blood pressure, their heart rate, their temperature, their respiratory rate, etc. Those kinds of things allow us to deliver these a little bit more easily, because we don't want, of course, our patients to experience toxicities. Now, the toxicities that we see with bispecific antibodies mirror those that we see with CAR T-cell therapy with some important caveats. So first of all, there's the early and then there's the more late and even delayed toxicities. For our earlier toxicities, the one obviously I mentioned already that we look for the most is our CRS and cytokine release syndrome. But we also look for neurological toxicities. We can also look for GI toxicities. Now we've come to appreciate that there is a colitis that can be associated more so with CAR T, but we can also see it with bispecific antibodies. And because these drugs are so effective in eliminating CD38 positive cells, although they're targeting BCMA, we do see hypogammaglobulinemia, cytopenias, and risk of infections. And so we'll talk a little bit about how we try and mitigate those. In the later effects, if we're targeting GPRC5D, we see, unfortunately, a lot of the effects of the fact that GPRC5D exists in other areas, like on taste buds, like on the nails, like on our skin and our hair. And so patients can experience those side effects that we'll discuss shortly. And thankfully, although we don't see a lot of it, patients can have a delayed neurotoxicity. This is something we see a little bit more with CAR T-cell therapy than with bispecifics, although it can happen. And I think we think the mechanism has to partly do with trafficking towards the brain. So let's think about each of these in turn and how we prevent, how we monitor, and how we manage them. Starting with cytokine release syndrome. As I mentioned, I think the general approach is let's not wait until it develops too aggressively to react. And so we try to prevent it even before it happens, knowing that if someone has a high burden of disease, we're going to CAR T, we should reduce that burden of disease. That puts people at higher risk of CRS. We know that we should monitor patients very closely. Now, it's not like we're taking their blood pressures every 20 minutes, but at that high risk periods in those first couple of days, we're checking them quite regularly, whether in person or remotely, with help of their care partner, so that we can pick it up sooner. We're also watching people's blood counts very closely, and in particular, some of those things that can indicate CRS, including their chemistry panel, their ferritin, coagulation studies, things that point towards more serious forms of CRS if they're going to happen. And then how do we manage it? Well, we may use simple antipyretics, making sure that people are well hydrated, but really the key response is the use of tocilizumab, whether it's given prophylactically, which is still to some degree under investigation, or given at very first grade, and typically at grade 1, we will try and introduce tocilizumab, and it's very effective at reducing the grade. If patients develop higher grade CRS, grade 3 and above, then they have low blood pressure. They obviously need to be admitted. We use vasopressors and other things, including sometimes steroids, to try and mitigate that. From an ICANS standpoint, from the immune effector cell-associated encephalopathy, we have also strategies to prevent them. If there are higher burden of disease, we've learned if we can reduce that burden, if someone's going to CAR T-cell therapy, that's going to reduce their risk of ICANS. We give them very effective bridging therapy, and then similarly, we monitor them. Some of those patients may require anti-seizure prophylaxis. Obviously, if we start to see signs and symptoms, and by the way, this could be as simple as a headache or as a more overt neurological symptoms. Sometimes we can even see facial palsies and other things like that. We want to intervene. And typically here, steroids are the key intervention. We tend to, and the tocilizumab is not so much used in this context. We tend to give steroids, but there are other things like anakinra or cetuximab that we may have to approach in the future thereafter. Another one of the things, of course, our patients are at significant risk for are developing infections, either because they're cytopenic, they're hypogammaglobulinemic, or just their immune system in general is incapacitated. We know that patients are at risk of infection. So we are very careful to monitor their IG levels. Literally every patient gets IVIG. I have to tell you that I just routinely use it in my patients on bispecific antibodies. As long as they're on active therapy, they're going to need it. Yes, we can measure their IgG level. It's almost invariably going to be below 400. If they're neutropenic, we may have to use growth factors, or we may have to use certain kinds of antibiotic prophylaxis. And then, of course, we're monitoring, not just looking at their CBC, but we really have a good conversation with the patient and their partner, looking for infections, if they have fever, if they have any focal symptom that points in that direction. There are a few viruses that we want to look for as well. We know that we will provide prophylaxis for some of them, but we can see CMV reactivation, hepatitis reactivation, these kinds of things we want to watch for and are careful to do that. And so typically we're giving PJP prophylaxis as well because of the pneumocystis risk when patients are being treated with these therapies. We give acyclovir or valacyclovir for the HSV or VZV risk. And then we don't routinely just give everybody antibiotics, but if someone has prolonged neutropenia, if they've had significant infections or repeated infections, we may want to do that. And of course, as I mentioned before, we're pretty much blanketing every patient with IVIG. Then what do we do about drug interactions, cytopenias? There's a lot of detail here, but we just have to remember that the CYP34A pathway is affected by these agents, and so we want to be careful if people are on antifungals and other things like that, and so we may have to make some switching. As I mentioned, from cytopenias, this is very routine. It tends to be shorter lived with bispecifics than what we see with CAR-T, but nonetheless, we have to be following them. We tend to follow patients' liver function tests as well because of the potential risk of various viruses, as I've mentioned. And we tend to not want to over nor under transfuse our patients. Obviously, we're following guidelines and protocols from institutions and from your district or wherever you are, but we tend to use GCSF quite liberally if someone remains neutropenic, but we're not immediately going to jump into transfusions of blood or platelets unless obviously they're at a threshold level or patients are symptomatic. And then let's talk a little bit about this delayed neurotoxicity. I have to say this is something that really concerned us in the early days of CAR T-cell therapy in particular, where we saw maybe 1 to 2% of patients experience things like Parkinson's and Guillain-Barré syndrome and so on several months after typically they've had the CAR T. We've seen it much less with bispecific antibodies, very rarely, but cases have been reported. And one of the key things is been able to reduce the burden of the disease before going into the CAR T-cell therapy in this case, or carefully managing patients then, because that puts patients at risk. We also have to be able to neurologically evaluate patients carefully. So we have these ICE scores that we follow carefully in the short term and potentially in the long term. We don't want to wait until what is a mild neurological event becomes a major deficit. We want to catch it earlier. And we've engaged our neurology colleagues much more than ever before, especially in challenging situations, because as you know, a patient doesn't come in saying, I have a neurological event. They're coming in with a sign or a symptom. Could it be infection and sepsis? Could it be something else that's happening? And so getting further input from our neurology colleagues is helpful. And then there's a lot of supportive care. We give a lot of seizure prophylaxis if there are neurological symptoms present that may be consistent with that. And again, sometimes steroids, as I noted before, can be help as well as other agents like anakinra and siltuximab. I did note that the side effect profile when we're targeting GPRC5D can be really quite different. And so it's very important that we understand this better, because our patients can experience very different things. Because of the taste buds, for example, we can see people lose their taste, have a dry mouth, and even reach a point where they don't want to eat. And a significant number of our patients in the early days lost a lot of weight. So trying to keep the mouth hydrated, sometimes even sour candies or things that can keep that taste bud active or give some relief to the patient can be helpful. Most of our patients end up seeing a dietitian or someone who can give them nutrition counseling to help them know where their calories are best come from. We know that it also affects the skin, the nails. Often people can lose their nails, so we can use moisteners and nail hardening features that can sometimes help patients through that period of time. It usually sheds and then doesn't continue to be an issue. And then, of course, it's very important that other specialties could be potentially involved if it becomes more dramatic, including our dermatology colleagues. From BCMA, I've really covered the majorities already, but just as a reminder that the vast majority of our patients are on, if not all of our patients are on IVIG replacement, as well as the prophylaxis for PJP and viral prophylaxis as discussed. Now, the other class of drug that obviously comes with its own separate potential for side effects is belantamab mafodotin. Thankfully, we don't see CRS. We don't see cytopenias to the same degree. We don't see the neurological events per se, but what we do see is these eye-related side effects. We know that the mafodotin, the drug, can potentially affect the outer layer of the cornea. There are sort of 5 layers of epithelium there, and it only affects that 5th outmost outer layer, but that can cause blurriness of vision and indeed dry eyes for patients. So they're given eye drops. We often will have them seen by an ophthalmologist before each treatment because they have to have less than grade 2 keratopathy to proceed with treatment. But perhaps the most important thing we can do with our patients is the way we dose the drug. I say this all the time. There's no drug we use in myeloma now the way it was first introduced. Often we end up we've gone from, twice weekly proteasome inhibition with bortezomib and carfilzomib now to once weekly. We've gone from higher dose immunomodulatory drugs to lower dose. And I think we're seeing this here too with belantamab mafodotin. Although the original trials with DREAM 7 and DREAM 8 gave the drug every 3 or 4 weeks, now we may give the drug the first time and the second time at 3 or 4 weeks, but thereafter, more often than not, I'm giving this drug every 8, 12, and sometimes even 16 weeks for patients as we learn how they metabolize the drug and what is best for them. And what's remarkable is that the vast majority of these patients, when they respond to the drug, they keep responding even if we have long drug holds. So we can do that legitimately, and we don't want to keep invoking this blurriness of vision of patients. It invariably goes away because that outer layer of the epithelium gets shed. It's not a long-term issue, but we don't want our patients to have that kind of challenge and discomfort. And of course, there are the other heme effects that we would typically manage as we would with any other particular therapy. Now, one of the things that we felt was particularly important is as we implement these strategies more and more, we want to be able to do them as an outpatient, and we want to be able to timely manage these adverse events. And so it's going to be important that these patients have a lifeline, as it were, an opportunity to call in, to reach out to us if these issues are present. Often we're even teaching our colleagues in the emergency department and other places in case these patients show up so that they can be managed. Now, as we think about incorporating this into practice, there's the pragmatic part of the step-up dosing and the prophylaxis and managing the side effects. Well, what are we thinking about how they fit with regards to sequencing? I've said many times that we have so many choices, and that's great to have that choice, but what makes me choose one over the other? What makes me feel that I go in one direction versus the other direction? And so I had the privilege of leading our ASCO guidelines that were just recently published to help guide a little bit of what we do. And there's lots of things that we came to say. One of the critical things we said is that a discussion about CAR T-cell therapy should be had at early relapse. There should at least be a discussion whether patients eligible or not, whether they can be feasibly given a CAR T-cell therapy. Because it's such a potent therapy and has shown such benefit, it should be considered, as indeed should now the bispecific antibodies and antibody drug conjugates. As I've said before, really we should be thinking about targeting BCMA at early relapse. And now that we have teclistamab and daratumumab in earlier relapse, we've updated our recently published guidelines to our living guidelines to say that this is a very important option for our patients. That the outcomes with Tec-Dara are remarkable, 3-year PFS over 80%, and so this should be considered. So we do want to make sure we consider CAR T. We see the benefit of these agents and discuss them with our patients. To not forget about antibody drug conjugates with belantamab mafodotin, knowing that it can be a very easy to deliver, especially in the community, and in particular in older and more frail patients. And of course, always remembering that as we do this, we engage our patients, we have that discussion with them, we look at the options available. Do we change the target? Do we change the modality? Always ensuring that we give our patients preference centerpiece as we have that discussion. Now, we, as the International Myeloma Working Group, and I had the privilege to be a part of this, we came together to think a little bit about sequencing. And I won't go over every element of all the 9 pieces of guidance that we gave around this, but just to remind ourselves that we have ways to optimize these therapies, that we typically want to ensure that we're not giving treatments that would damage T cells, and our usual classes of agents of proteasome inhibitors, immunomodulatory drugs, and monoclonal antibodies do not do that. We've also seen recently drugs like selinexor, the incoming agents of cell mods don't adversely affect T cells, because we want to think long-term strategy for our patients. Although we don't save, as it were, the best for last, we give our patients the best therapy now. We don't want to burn bridges down the line. And so we want to avoid those things that may compromise T cell function, like bendamustine, like alkylating therapies, as we treat our patients. And we also noted the importance of that bridging therapy, as I noted, not only to increase the efficacy of a treatment, but to reduce the toxicity of that CAR T cell therapy. And so you can see each of these here, that it's important for us as we retreat, that we can leverage the BCMA target more than once, but we want to do so in a way that preserves the T cell, that allows us to re-engage that target for the best efficacy possible. And so, of course, as we think about how we select our bispecific antibodies for patients, there's so many factors. How rapidly is their disease growing? What is their preference? Do we have access to CAR T cell therapy? What is the best combination? Do we want to target BCMA? Do we want to target a GPRC5D? And a lot of this, of course, will depend on the patient's frailty. In the early days, we were a little bit more nervous of using bispecific antibodies in older and more frail patients, but I have to say that we've really moved away from that now. We've been able to use it much more effectively, even in older and more frail patients, as we have been able to manage these side effects that much more. And so again, more thoughts around sequencing. One of the benefits of giving CAR T before a bispecific is that you engage the T cells and then they have a T cell rest. But one of the things we're doing often now with bispecific antibodies is we're treating patients and considering not only dose reduction down to every other week and once a month, sometimes even dose limiting, like stopping treatment, fixed dose, so that patients not only can have the convenience of not having ongoing treatment, but can actually also rejuvenate their own T cells. And that allows for even more options later. And so now many studies are being reported and done, as you can see here, of showing that, oh, well, I can give CAR T and then the bispecific antibody, or I can give the bispecific antibody and later give an antibody drug conjugate. So each of these sequencing options are now becoming much more available to us, and the evidence for it is particularly growing. One particular here, this real-world study looked at patients who had been treated that if they had prior belantamab mafodotin, they could still receive teclistamab therapy and have the efficacy from that. So as I noted, the BCMA target is quite a resilient target, and we want to make sure that we can leverage it more than once. And so getting belantamab mafodotin now does not prevent my patient from being able to have a BCMA-directed therapy later, including teclistamab. We've also seen this, that we can give the bispecific antibodies after someone has had a CAR T. That naturally makes sense because those T cells typically are given a bit of a rest. Most T cells will persist for 4 to 8 months after we've administered them, but they still will persist there. Most of them won't persist afterwards, and so their T cells are now being given a rest. And so it's no surprise that now we can see after patients have had CAR T, we still have really remarkable response rates with bispecific antibodies north of 65 or 70%, as we would typically see in other areas. Well, that's all we have time for today. I'd like to take a moment to thank Johnson & Johnson for their support.